In this video, we will learn about the drug cephalosporins. Cephalosporins are a class of broad spectrum antibiotics that are used to treat bacterial infections, and this is the class of beta lactam antibiotics, which also contains penicillins. So the first cephalosporin that was isolated in 1945, and the story of discovery is pretty interesting. They were isolated by an Italian pharmacologist from a fungus which was called as Cephalosporium acrimonium, and this fungus was found in a sewage outlet in Italy, and from that the first cephalosporin, which was called as Cephalosporin C, was actually isolated, and the journey of cephalosporins began from that point. Let's start with the chemistry of the cephalosporins. So, as we have already discussed, that cephalosporins, they have a beta lactam ring. So this is the nucleus of cephalosporins, in which a beta lactam ring is attached to another ring, and together these they form the nucleus of the cephalosporins. So this nucleus, it is common in all the cephalosporins, and there are two R groups, R1 here and this R2 here. So these two R groups, they are modified, and the modification of these groups has yielded hundreds of potent compounds with low toxicity and more therapeutic value. So this is how all the cephalosporins are different on the basis of this R group. And apart from these groups, the basic nucleus of a cephalosporin is common, which is given or which is described in this figure. Now we'll move towards the classification of the cephalosporins. So they are classified into 5 major groups on the basis of their spectrum of antimicrobial activity. We'll discuss each group separately and we'll go into the details. So the first generation cephalosporin, it is the first first class of cephalosporin. It has 6 drugs. We have cefazolin, cefadroxil, cephalexin, cephalothin, cefapyrin, and cephradine. So the names are a bit difficult to remember, but you'll have to find some way in order to remember the name, because these 6 drugs, they come under the first generation. So they share the common antimicrobial spectrum. That is why they are placed in a first generation cephalosporin. We'll start with the pharmacokinetics of the drug. So cefazolin, it is the only drug that is available in IV formulation, or it is given as a parenteral cephalosporin. This drug has, apart from cefazolin, all these drugs, they are given in the oral formulations. So the absorption of IV cefazolin is approximately 100%, because it is given as in the parenteral route, and the absorption of all the other drugs, cefadroxil, cephalexin, cephalothin, cefapyrin, and cephradine, they are variable, and it actually varies from drug to drug. They are well distributed in all the areas of the body except for the CNS. So they do not go into the CNS. And all these drugs, they are excreted by the kidneys, which means that they have renal clearance, and the doses of the drugs, they need to be adjusted according to the renal function of the patient. So let's talk about the spectrum of activity and clinical uses of the first generation cephalosporins. Now, as we know that we divide bacteria into aerobic and anaerobic, and in aerobic and anaerobic, there are further categories of gram positive and gram negative. So this here I have given a brief overview of bacteria classification. So the first generation cephalosporins, they have activity against gram positive bacteria, and among the gram positive bacteria, they have activity against pneumococci, streptococci, and staphylococci, which means that all these organisms, they cause upper respiratory tract infections, they cause surgical site infections. So that is why the first generation cephalosporins, they are used for the treatment of urinary tract infections. They're used in the prophylaxis of surgical infections. They're used in the prophylaxis of the in the surgeries, different kind of surgeries. And these bacteria, they're also notorious for causing skin and soft tissue infections. So these drugs, they are used to treat skin and soft tissue related infections. The first generation cephalosporins, they do not have a very good gram negative coverage, but they have some activity against E. coli and Kleb and if the bugs, they are not resistant to first generation cephalosporins, they can be used, these drugs, they can be used for the treatment of UTIs caused by these organisms. Now, the anaerobic coverage of first generation cephalosporin is relatively very poor, but there are some anaerobic bacteria which includes pepto streptococci and peptococci. So these bacteria, they are anaerobic and they cause abdominal infections. And the first generation cephalosporins, they have very little activity against these bacteria. So the activity is very little. So they're not used for the treatment of any sort of abdominal, intra-abdominal infections. So this was the overview of first generation cephalosporins. We'll move towards the second generation cephalosporins now. In the second generation cephalosporins, we have actually 8 drugs, which include cefaclor, cefuroxime, cefproxil, loracarbef, cefonicid, cefoxetine, cefotetin, and cefmetazole. So these are the 8 drugs that come in the second generation of cephalosporins. We'll start with the pharmacokinetics of these drugs and then move towards the clinical activity or clinical uses of. So cefaclor, cefuroxime, and cefprozil, they are given in the oral formulations. And apart from these, all these drugs are given in the IV or IM injection form. The IM administration is usually painful and it should be avoided, and the IV infusion is usually preferred over the IM injections. And the the first 3 drugs of this class can be given as the in the oral formulations. We can also use that. They achieve very good concentrations after the oral dosages, and they are well distributed throughout the body except for the CNS. Now, these drugs, they have from all these drugs, we have these 3 drugs which I have separated here. They are also called as cephamycins. Now, see, what are cephamycins? These are the drugs that have a unique characteristic of anaerobic coverage. So they cover the anaerobic bacteria, which the rest of the cephalosporins does not cover, and that is why they are called as cephamycins, and they are placed in another class or another subdivision of the second generation cephalosporins. So these are the 3 drugs: cefoxetine, cefotetin, and cefmetazole. So they are combined or together, they are called as cephamycins because they have anaerobic coverage as well. Now we move towards the spectrum of activity and clinical uses of cephalosporins. So, as we have discussed bacteria in detail in the first generation cephalosporins, so they have the activity of first generation cephalosporins, and along with that, they have extended gram negative coverage, which means that they are active against the gram positive bacteria, streptococci, and staphylococci. So they can be used for the treatment of skin and soft tissue infections, and they can also be used for the treatment of upper respiratory tract infections. The upper respiratory tract infections, which means that they can be used for the treatment of sinusitis. They can be used for the treatment of otitis, which is the infection of the ears, and they can also be used for the treatment of lower respiratory tract infections, which basically include strep or staph pneumonia. But they do not cover or they does not have activity against the methicillin resistant or the staphylococci, or which is also called as MRSA. So do not have any activity against MRSA. So in gram negative, they cover E. coli and Kleb, which we have covered in the first generation cephalosporins. But apart from that, they also have good activity against Haemophilus influenza. Now, Haemophilus influenza is basically notorious for causing lower respiratory tract infections or pneumonia. So we use second generation cephalosporins in the treatment of pneumonia as well, but we must check the susceptibility pattern of H influenza in order to avoid any resistance, because now we have many strains that are resistant to Haemophilus influenza. Now there is another gram negative bacteria which is called as Moraxella catarrhalis. Now this Moraxella Now, this bacteria, Moraxella catarrhalis, it's a gram-negative bacteria, and it usually causes upper and lower respiratory tract infections. Now, the second generation cephalosporins, they have activity against this bacteria, and they are used to treat sinusitis, otitis, and lower respiratory tract infections that are caused by these bacteria. Now, we discussed three cephalosporins, which were called as cephomycins. They have very good activity against anaerobes, which includes the bacteria Bacteroides fragilis. Now, this is an anaerobic bacteria, and it is very notorious for causing intra-abdominal infections, and it causes peritonitis. It causes diverticulitis, and it also causes pelvic inflammatory disease. So we use cephalosporins, we use cephomycins for the treatment of these infections because they have activity against the anaerobic bacteria that causes these infections. Although the cefuroxime, it does crosses the blood-brain barrier, it is very less effective for the treatment of meningitis. So we do not use any second generation cephalosporin for the treatment of central nervous system infections. In third generation cephalosporins, we have 7 drugs, and all these drugs, among all these drugs, they have apart from cefoperazone, all the other cephalosporins, they achieve good levels in the central nervous system as well. Now we'll start with the dosing of these drugs. So ceftriaxone and cefixime, they're usually given in once daily dosing for most of the infections. However, ceftriaxone is given in BD when we are treating the central nervous system infection, when we are treating meningitis, or if we're treating endocarditis. So in these conditions, we give ceftriaxone in BD dosing. Apart from that, it is given as once daily dosing in all the other infections. The cefpodoxime is usually given in BD dosing. We give it twice daily, which means that we are going to dose this drug twice daily. Cefoperazone can be given twice daily, or it can be given 8 hourly. So both the dosing schedules are being used for cefoperazone. Now the rest of the drugs, they are given as 6 to 8 hourly, which means that we have to give them, we have to administer the doses 3 or 4 times per day. So they all achieve good penetration in all the body tissues. And ceftriaxone and ceftazidime, they are unique in such sense that they crosses the blood-brain barrier and they have good penetration in the CNS, and they are usually used for the treatment of meningitis. Now, all these drugs, they are excreted by the kidneys, except for 2 drugs which are excreted by the liver. So the 2 drugs that are excreted by liver are ceftriaxone and cefoperazone. So these are the 2 drugs that are excreted by the liver. And apart from all these drugs, apart from these two, all these drugs, they are excreted by the kidney. And why we should know the mode of excretion? Because the drugs that are excreted by the kidney, The doses have to be adjusted according to the renal function. If the patient has chronic kidney disease or acute kidney injury, we need to modify their doses according to their renal status. So there is no dose adjustment required for these two drugs in case of renal uh, any renal failure. No dose adjustment is required. Now we'll move towards more important thing of these drugs, which is the spectrum of activity and their clinical uses. So they are broad spectrum antibiotics. They retain the activity of the first generation and second generation cephalosporins, and along with that, they have extended gram negative coverage, which means that they cover more gram negative bacteria. So they cover the bacteria that we discussed in first and second generation cephalosporins, and along with them, they also have extended gram negative coverage, and they also, because they have the ability to cross the blood-brain barrier, so we use them in the treatment of meningitis as well. So they have activity against providentia. Now, providentia is a gram-negative bacteria, and what it does that it causes gastroenteritis, and it also causes bacteremia. So we use cephalosporins in the treatment of gastroenteritis and bacteremia caused by caused by the providentia. They have activity against serratia, and what serratia does is that it is very notorious for causing UTIs. It causes pneumonia, and it also causes bloodstream infections. So in all these situations, if the serratia is sensitive to third generation cephalosporins, we'll use them against the treatment of urinary tract infections, pneumonia, and bloodstream infections caused by the serratia. Now there is another bacteria which is called as Citrobacter. What the Citrobacter does is that it causes gram negative. It's a gram negative bacteria which causes neonatal meningitis. So we use cephalosporins, third generation cephalosporins, in the treatment of neonatal meningitis as well. Citrobacter also causes UTIs, which is basically urinary tract infections, and it also causes sepsis due to secondary to bloodstream infection or any other source as well. So all these indications, we use third generation cephalosporins against all these bacteria. Now they also have activity against Haemophilus influenza, and Haemophilus influenza is very notorious for causing pneumonias. And we use third generation cephalosporins for the treatment of pneumonia that is caused by the Haemophilus influenza. And they also have activity against Neisseria, which causes gonorrhea, and we use cephalosporins for the treatment of gonorrhea as well. Now we must check the susceptibility pattern of these organisms if we're treating, because there are many resistant strains of these bacteria which can combat against these drugs. So we must know the sensitivity pattern of the bacteria if we're treating any patient. So, in order to summarize, they are used for the treatment of meningitis, they're used in the treatment of empirical therapy of sepsis, they're used in the treatment of gonorrhea, gonococcal urethritis, and cervicitis. They're used to treat various bloodstream infections, and also the third generation cephalosporins, they are used for the empiric therapy of sepsis if the patient has febrile neutropenia. So these drugs, they are very important because they have wide variety of uses, and they're very commonly employed in the treatment of various infections. So we must know the susceptibility pattern and the chemistry and the pharmacokinetics of these drugs. They're very important drugs. Now we'll move towards the fourth generation of cephalosporins. And the fourth generation of cephalosporin, it only has one drug, which is called as cefepime, and it is more resistant to hydrolysis by the beta lactamases. However, third generation cephalosporins, it is hydrolyzed by the extended spectrum beta lactamases. Now, cefepime, it has very good activity against Pseudomonas aeruginosa, which is a very notorious drug. So it's a very notorious drug, and that causes wide variety of hospital-acquired infections. And cefepime has good activity against Enterobacteriaceae, which means it has activity against E. coli and Kleb and pneumonia and all the infections that are caused by these bacteria. They also have activity against staph, which is a gram-positive bacteria, which is responsible for causing pneumonias and variety of skin and soft tissue infections. And it has also good active against streptococcus pneumoniae and the other strains. So they're used. These bacteria, they cause respiratory tract infections and skin and soft tissue infections. So we'll use cefepime in the treatment of these infections. Now, cefepime, it also has good activity against Haemophilus, which causes pneumonia, and it also has good activity against Neisseria species, which causes gonorrhea and gonococcal cervicitis and urethritis, and we can use cefepime in the treatment of all these conditions. It penetrates very well into the cerebrospinal fluid, so we can use it for the treatment of central nervous system infections as well. The excretion of cefepime is usually by kidneys, so we must adjust the dose of cefepime if we're dealing the patients who have renal failure. It has a half-life of 2 hours, and it has to be given every 6 to 8 hourly. So it has the short half-life of 2 hours. So we have to give it multiple times in the day. So this was all about the cefepime. Now we'll move towards the fifth generation cephalosporin. And the fifth generation cephalosporin, it also has one drug, ceftaroline. Now, ceftaroline, it is a prodrug of the active metabolite. Ceftaroline is usually given in the form of a prodrug, which is called as ceftaroline fosamil. And it is metabolized in the body to the active drug, which is ceftaroline. Now, it is the first drug to be approved for clinical use in the USA from the fifth generation cephalosporin. And the most unique characteristic of this drug is that it is the only cephalosporin that has activity against MRSA. MRSA is basically methicillin resistant Staph aureus, and all the other cephalosporins, they are usually resistant to this bacteria, and this ceftaroline, it is the only cephalosporin that has activity against MRSA. So this was all about the cephalosporins. Now we'll move. Now all these drugs, because they have a number of clinical uses, they have some adverse effects as well. So we will discuss them one by one. The first and the most common adverse effect of cephalosporin is usually allergy. They are sensitizing, and they may elicit a variety of hypersensitivity reactions, and they are identical to those of penicillins. So they can cause anaphylaxis, they can cause fever, they can cause skin rashes, nephritis, which is basically the inflammation of nephrons in the kidneys, and that can cause granulocytopenia, which is a kind of cytopenia in which there is reduced formation of granulocytes, and they can cause hemolytic anemia as well. So all these reactions, they are immune mediated because cephalosporins, they can be sensitizing. Now, however, the chemical nucleus of cephalosporins is sufficiently different from that of penicillin, so that some individuals, if they have a history of penicillin allergy, they may tolerate cephalosporins. This is a very frequently asked question. So, the frequency of cross allergenicity between the two groups of the drugs is usually uncertain, and it is probably around 5 to 10%. So, if the patient has a life-threatening or anaphylactic reaction to penicillin, cephalosporins can be avoided. But if the reaction or to the penicillin was mild, or it was just skin rashes or any mild reaction, we can give cephalosporins safely to those patients as well. And also the cross allergenicity, it is appears to be more common with the penicillin and the early generation cephalosporins, which means that if the patient is allergic to penicillin, they may be allergic to the early generation, the first or second generation cephalosporins. Apart from them, other cephalosporins, they can be given safely in a penicillin allergic patients, and the allergy, it may manifest as anaphylaxis, which is a life threatening condition, or it may manifest as a mild fever or just skin rashes. Apart from allergy, cephalosporins, they can cause renal toxicity, and there is one drug which was called as cephalosporin. It was withdrawal from the market because of this potential toxicity. So they can cause interstitial nephritis, and they may cause renal tubular necrosis. So both these are different mechanism of the same effect. The same effect is basically renal toxicity, and it can occur through the interstitial nephritis or through the tubular necrosis. So both these reactions, they can occur after the administration of cephalosporins. Now there are certain cephalosporins which can cause bleeding disorders in patients, and these drugs, they include the cephamycins, which are second generation cephalosporins, which include cefotetin, and cefmetazole, and the most commonly used drug, cefoperazone. Now, all these drugs, they have the potential to cause hypoprothrombinemia, and they can cause bleeding in the patient who are taking these drugs. So, what can we do? That we can give these drugs, and along with this, we can give vitamin K to these patients. Vitamin K will actually prevent the bleeding disorders that are caused by these drugs. So, we'll give vitamin K twice weekly in order to prevent this adverse effect of the cephalosporins. Now, all these drugs, they can also causes disulfiram like reactions if they are administered with the alcohol. So we must keep that in mind as well. So we must know the adverse reaction profile of cephalosporins as well when we are using these drugs to treat our patients.